tobacco policy has long been recognized as a major concern in public health. It is also a key issue in political science and public policy research for four main reasons. First, as a policy problem, it has some unusual features. Smoking is legal, but represents the number one preventable cause of premature death and disease in the world. Second, tobacco policy contains elements of both stability and instability. It provides one of the most significant examples of major policy change in the developed world. A post-war picture characterized by limited governmental intervention to control tobacco has been replaced, in many countries, by a comprehensive set of measures designed to reduce smoking and limit the activities of tobacco companies and, at the global level, by a major public health treaty, the Framework Convention on Tobacco Control (FCTC) of the World Health Organization (WHO). Third, it provides one of the most important examples of power and politics in the modern world. We can link initial levels of stability and continuity to a great imbalance of power and resources in favor of transnational tobacco companies at the expense of anti-smoking groups. Fourth, it provides an extensive source of information on comparative public policy processes and outcomes. In particular, it allows us to examine the policy divide between developed and developing countries as categorized by the United Nations. Policy has changed markedly, albeit unevenly, in the former, but it has generally lagged in the latter, prompting many government leaders, international organizations and NGOs to try to bridge the gap through international agreements and policy transfer. While there is some evidence of policy transfer success, and a significant shift to global tobacco control policy, there is also evidence that tobacco companies still have a strong hold on global policy and are often supported by governments. This prompts us to ask two key questions. 1. Why is there often such a wide gap between the size of the policy problem and the government response? 2. Why, if the problem is the same across the globe, does policy vary so markedly across political systems? This book represents the first major attempt by political scientists, writing from a unified perspective, to explain global tobacco policy. This approach sets it apart from public health accounts more interested in what public policy should be rather than what it is and why policy decisions were made. It also sets it apart from edited social science volumes which present useful contributions on individual countries from a range of disciplines, but without a central unifying theme or a means to compare policy development systematically across different political systems over time. The plan of this chapter is as follows. First, we identify the size of the policy problem. Second, we introduce the argument that there has been a delay between the onset of the problem, recognition of the problem in policy circles, and the policy response, by drawing on the public health advocacy literature. This literature is relatively extensive and displays a highly critical assessment of the policy records of governments and the power and behavior of tobacco companies. Third, we outline a political science approach to tobacco policy. We initially relate the delay in policy response to classic discussions of power within political systems. For example, drawing on the second-phase discussion of power, we suggest that tobacco industry power is exercised to maintain barriers to policy change, initially to reinforce the dominant social attitude that treated smoking and tobacco companies in a positive light and, subsequently, to influence the policy process to keep the issue of tobacco control off the policy agenda. This discussion of power and policy sets the scene for the remainder of the book. In Chapter 2 we introduce a framework, based on contemporary theories of public policy, to study policy stability and change. We use this framework to analyze tobacco policy change at different, complementary, levels of detail and breadth, across the globe. In particular developed countries, in groups of developed countries, and, across developing regions. We identify the nature of tobacco policy, examine how we measure policy change and explain stability and change with reference to 5 main factors: institutions, agenda setting, policy networks, the socio-economic context and the role and transfer of ideas. Finally, we synthesize the empirical content of each chapter and outline the potential for the tobacco policy experience to inform contemporary theories of public policy. The tobacco problem. The medical and public health literature suggests that few health conditions have had as catastrophic long-term consequences as tobacco use. It contributes to 1 in 10 deaths worldwide, over 5 million per year. On current trends, the number of deaths is expected to increase to between 8 and 10 million by 2030. In the 20th century, tobacco use killed over 100 million people, and the WHO estimates that the death toll in the 21st century could reach 1 billion. Tobacco kills an estimated 1/3 to 1/2 of its regular users, which means that of the 1.3 billion smokers today, 390 to 650 million will eventually die from this behavior. The U.S. Surgeon General indicates that tobacco use is hazardous to almost all parts of the human body. Cigarette smoking especially leads to cancer, respiratory and cardiovascular diseases. In other words, it undermines life and the quality of life. In the U.S., tobacco accounted for 18% of 1.2 million deaths in 2000, compared to 17% from poor diet/physical inactivity, 4% from alcohol, and less than 1% from illegal drugs. The proportions are similar in countries such as Canada, New Zealand, and Australia. Tobacco-related diseases, especially lung cancer, have declined since the mid-1990s to reflect a drop in smoking. Nevertheless, in the U.S., deaths resulting from the direct consumption of tobacco, excluding passive smoking from second-hand smoke or environmental tobacco smoke, are almost twice as high as the combined total for alcohol, cocaine, heroin, homicide, suicide, car accidents, fire, and AIDS. Yet, the resources spent on tobacco control are relatively low, especially in comparison to the costs of treatment in the healthcare system. Tobacco is increasingly a developing country problem. By 2030, over 70% of tobacco-related deaths may occur in the developing world. Of the over 1.3 billion smokers in the world, almost half live in China, 30%, and India, 17%. The increasing rate of tobacco use has resulted in an increasing rate of tobacco-induced morbidity and mortality, with a long gestation period for some tobacco-related diseases. Countries such as China and India have been experiencing dramatically higher death rates from smoking since the 1990s. Tobacco attributable mortality for males in China was 12% in 1998, and that of India is expected to reach 13% of total deaths by 2020. Although India is a relatively poor country with a greater number of sources of death related, for example, to sanitation, its mortality rate is already markedly higher among tobacco users than non-users. The number of cigarettes consumed in the developing world has risen from 1.1 billion in 1970 to 3.4 billion in 2000, compared to 1.5 billion in the developed world in 1970 and 2000. While the per capita rate of consumption is still much higher in developed countries, that figure is falling. In developing countries, the figure is not only rising, but also set to rise much more significantly in line with the tobacco epidemic model. As Figure 1.1 suggests, the model consists of 4 stages. In Stage 1, lasting 1-2 decades, male and female smoking prevalence starts at very low levels before rising rapidly, and before any tobacco-related deaths are evident. In Stage 2, lasting 2-3 decades, male smoking prevalence rises rapidly and reaches levels far higher than female, peaking at 50-80% of the male population. By the end of this stage, illness and deaths attributable to tobacco are rising rapidly, accounting for 10% of all male deaths. Tobacco-restrictive activities in this stage are poorly developed, and cessation support activities are uncommon. In Stage 3, the prevalence of male smoking begins to decline and the prevalence of female smoking plateaus, though smoking prevalence among younger women can reach levels close to that of males. Knowledge of smoking health hazards is also more widespread. However, during this stage, the incidence and prevalence of tobacco-attributable disease continues to rise rapidly and peak at 25-30% of male mortality, with tobacco-proportionate mortality even higher in the middle age groups because of the time lag between tobacco exposure and the related illness and death. As knowledge of smoking hazards spreads, the receptivity for tobacco control increases, and tobacco control activities become more organized, successful, and comprehensive. In the final stage of the model, smoking prevalence for both sexes continues to decline at slow but similar rates, but smoking attributable death rates remain high. The public health view refers to the identification of 5 key ideas. 1. There are clear health dangers related to tobacco use and its exposure. Passive smoking. 2. Tobacco is an addictive product and nicotine is an addictive drug. 3. Tobacco use causes an economic burden on individuals, employers and governments. 4. The tobacco industry is responsible for the use and spread of tobacco worldwide and its activities need to be controlled. A comprehensive approach to tobacco control, a composite of measures and programs that reinforce each other to reduce the use and spread of tobacco, is required. To know more, read the book Global Tobacco Control by Kearney, Studler and Mahmoodou.